Okay, welcome back everyone. So we are going to start now a special session in which we are going to acknowledge the work of two scientists that received the oral presentation award on this workshop. Before that, I would really want to thank the scientists in our laboratories, Gwendolyn Barceló, Antonia Obrador, and my laboratory at the Health Research Institute of the Balearic Islands, and especially Dr. Daniel Lopez for his support and help on many different administrative issues to go through, and Dr. Miquel Fiol for his support to carry out this second workshop. Okay, without further introduction, I want to call to the podium Dr. Marta Duen As. Dr. Marta Duen As is a scientist in the Molecular and Translational Unit at the CIEMAT, Madrid. She will be presenting today her study, Vladimir, a highly sensitive, non-invasive test for non-massive invasive bladder cancer diagnosis and response to BCG and BCG response. Dr. Duen As, congratulations on your study, and we would like to give you this certificate recognizing this award. Thank you very much.
Well, first, thank you very much to the organizing committee to be here. I mean, after all this confination, I think that we really appreciate to have a physical contact between us. So thank you very much. And thank you very much for this award. It's the first time I received an award before I presented the work, but that's nice to know. I will present here this work that I'm confessed that we are very proud of. And it's a new non-invasive system for detection of bladder cancer based on urine samples that we have called Vladimir from Bladder Diagnostic Mir. And as well, I will present some preliminary data of something related that we have done for BCG therapy response prediction. Bladder cancer is the ninth frequent cancer, and it has it's diagnosticated around 500,000 new cases per year, and more than 24,000 just in Spain. The incidence is around 20 per one. Sorry, I have a cursor. No tengo cursor aquí. Okay, thanks. An incidence of 20 per 100 persons per year, with a mortality of between 8 and 9 per 100 persons per year. It has more frequency and appearance in men than women, in a ratio 4:1, and it frequently appears in older patients, with 70% of the cases over 65 years. At diagnostic, most of the bladder cancer are divided in two main groups: the non-muscle invasive bladder cancer with a better prognosis and accounting for around 70% of all the cases. This, even though it has a better prognosis, it's treated by transurethral resection and localized therapy, but it has its main problem is that it has very high recurrence rates. What obligates the patients to follow up periods for up to 5 years, with therapeutic visits for 2 to 4 times per year, with the high risk of progression of those recurrences. The rest 30%, for the new diagnostic cases, cancers are already muscle invasive with a poor prognosis, with a high incidence of distal metastasis in 2 years, and overall survival of less than 30% in 2 years period. At present, the more employed diagnostic combo is the combination of cytology of urine sediment that it is based on the characterization, the quantification and characterization of tumor cells in the urine sediment, and it has a very high specificity, over 28%, but it has a very low sensitivity, mainly on those tumors that are low-grade tumors. The gold standard is cystoscopy, and it's true that even if it has a very high sensitivity and high specificity, it's a very highly invasive technique, and with a high variability between intra and inter-observer, based mainly on the skill of the physician that does it. So we are, as many researchers, working to find a good liquid biopsy, not invasive biomarker for bladder cancer diagnostic. And as it's obvious, the best liquid or the best fluid for this kind of diagnosis is the urine, since it's in very close contact with the tumor. There are several commercially available kits that are mainly based on messenger RNA and proteins quantification in urine or urine sediment. We are approaching this fight to find a very good bladder cancer biomarker, focusing on microRNAs. MicroRNAs are very stable molecules, and it's present in every tissue and biofluid sample. It could be purified from frozen, fresh tissue, plasma, serum, saliva, urine, and any source. And it has been reported that efficiently classifies different tumors, even better, with better sensitivity and sensibility that messenger RNA profiles. And for our as an improved value for a biomarker, it shows very low inter-individual variability in terms of healthy individuals. The main drawback of microRNA is that it has very low expression levels, so it needs very high sensitivity techniques to be able to use it. So we first made a previous study that it was published 5 years ago, and I will just point out what it was important for the present presentation, and it was to evaluate whether microRNAs were better or more suitable biomarkers than nuclear RNA or messenger RNA in urine. For that, we use 3 mRNAs normally used as a normalizer, as well as nuclear RNAs, and 3 microRNA that at that moment were not associated with bladder cancer. And as it shows here, and it was published in Journal of Molecular Diagnostics, the microRNA effectively were more stable than the messenger RNAs or nuclear RNAs, and were actually shows less variability in terms of qPCR determination and in normal finder executions. So what we decided was to actually evaluate differential expression profiles of microRNA expression data we already have in the lab from normal and tumor tissues from not muscle invasive bladder cancer samples. And from that data to extract microRNA differentially expressed in tumor tissue compared to normal tissues, and then validate those microRNAs using an extended cohort in tissue and third phase validation of differentially expressed microRNA in urine samples. This validation was made in two different steps. First, a proof of concept in the urine samples, and the second, a blind validation of a new cohort of urine samples. From the first, we found 34 microRNAs differentially expressed in tumor that were 16 induced and 18 repressed, that were furtherly validated by qPCR, almost all of them, except one that it was not determined. I show here the fourth more that better separate samples from tumor samples from not tumor tissue. And just as an example of what we did was just to make a t-test between the both sample types and to calculate the area under the curve in rock analysis. But as we mentioned before, the normalizer here in tissue, as it's widely used, it was a nuclear RNA. In terms of urine, we knew that there was, even if probably was possible, it was not a good normalizer. So what we decided was to evaluate different mathematical algorithms that avoid the need of this of the use of a normalize. And we found that for a simple ratio of microRNA for 145 and 182, one that it was up and the other one that it was down, we perfectly divided or separate the normal tissue from tumor tissue. So with that in our heads, we went down and then make a proof of concept evaluation using 124 urine samples from bladder cancer patients and 24 samples from not healthy individuals. And what we found that, in fact, was that without normalization, the separately use of each microRNA separately did not give us any good prediction. However, when we combine it and calculate the ratio of 145 microRNA 145 and 182, not perfectly, but very well accurately separate tumor samples from healthy urines. So with that result, that was a sensitivity and specificity over 90%, that it was even better than the combo between cytology and cystoscopy, and much better than most of the commercially available kits. We went in a collaboration with a group from Nuria Malatz at CENIO. They have samples from previous studies in bladder cancer, and we received 84 samples that were all from urological patients. Some of them from incidence patients, that means that are patients that have symptoms for the first time, and recurrence patients that are patients that have a previous history of bladder cancer. And half of them were negative and half of them were positive. And what we actually found is what, in a blinded way of doing it, when we classified the total samples from bladder cancer patients of the urological controls, we were able to classify more than 20% correctly. But even if we divide it between incident and prevalent, what it shows is that the previous history of bladder cancer on a patient was not an artifact in our diagnostics. So from this, our take-home message is that Vladimir assay is a non-invasive tool that accurately diagnoses bladder cancer. So following this very good result, what we did was to establish the same kind of a study for BCG prediction. Why BCG? I mean, in the non-muscle invasive bladder cancer therapeutic ocean, they are divided in two main groups, the low-grade or low-risk bladder cancer and the high-grade or high risk of recurrence and progression. In this second group, the main therapy that is being used, and I must say that it's the first and more successful immunotherapy till today, it's a BCG instillation that develop a very high inflammation process that culminate in around half of the cases in an anti-tumor response. But the problem is, as I say, is that this instillation generates a very high or very potent inflammation procedure, and only half of the patient actually responds to that therapy. So it will be good to have some predictor of this successful for this therapy. So what we did was to do exactly the same procedure, but in this case, just with a patient responder and not responded to BCG therapy. First, tissue. Second, validation of an extended cohort. And then third, urine samples. And we actually found, but in this case, it was not the microarray data, but nanostring, but it's a similar approach. And we found 26 microRNA differentially expressed, 7 induced and 19 repressed. And the validation, we haven't completed that yet, but from 18 that we have evaluated, 6 are induced and 2 repressed. That's the same that we found, I mean, just validating what we found in the first cohort. And we did each microRNA separately, and we have proved all the combination that we have assessed so far. And we have found that this combination and this other combination has very good values for ROC analysis. And as a preliminary data, and as I say, we have still many microRNAs to evaluate. We have found that this combination of microRNA 182 and MIR21 actually give us around an 80% of accuracy in BCG response prediction. And I must say that these are samples of urine samples previous of the RTU. So it gives the physician times to take other possibilities or options for other therapies. So as conclusion, I must say that we have found that microRNA are good molecules to be assayed in liquid biopsy as biomarkers or on urine samples, that Vladimir, it's a novel bladder cancer diagnostic system based on non-invasive urine detection method that is actually being proved or is under evaluation in the 12th of October hospital. And is capable to accurately discriminate bladder cancer patients independent to confounding factors such as hematuria, cystitis, or previous bladder cancer tumors. And as preliminary data, we have identified several microRNAs capable to predict BCG response, but these are just preliminary work. And even if I present this data, it's a lot of people involved on it from our group, mainly Christian, Monica, and Jesus Paramio, and of course all the urologists and oncologists from the 12 Octubre University Hospital, and the group of Nuria Malat and Francisco Real from CENIO. Thanks.
Thank you very much, Dr. Duen As. We only have time for a very quick question if someone has a question. I do. We understand that it's sometimes very complex to translate data from microarrays or next-generation sequencing into easy or low complexity assays like PCR. I saw in your presentation that you have done that in all the microarrays. You have tested all the microarrays using qPCR, and you assign different asterisks, 1, 2, or 3. Could you tell us how do you do that? Did you do it directly on the urine samples, or
Yes.
was that on cell lines? How do you do that?
No, I mean, we start from paraffin-embedded tissue from patients. And for the first, sorry, that was for the second study. For the first study, we start from fresh tissue, from transurethral filtration tissue. And what we took as a normal tissue, it was not healthy individual, of course, was a normal urothelium from patients. So that's something I didn't say because, I mean, it has not time for everything, but it's important. And then once we got the differential expression of microRNA patterns, and just because we have seen in animals that it were better prognosis, or it was more accurate, the microRNA profiles than the messenger RNA profiles, actually. What we did was we tried to validate every one of them in new samples, and in that case, it were paraffin-embedded samples. So
but
we started the RNA.
The asterisk you assign is based on the quality of the PCR, or is based on the information of the microRNA? It's because the assay did not work, so we should not test that by PCR? Sometimes the microRNAs are very tricky on PCR.
I must say that using good probes, I mean, except one in the second study, I must say that we didn't have any problem with any of them.
Okay.
And of course, the thing is that the one we obtained from the first study are the ones that are more expressed, so to say, because if it's not, you probably lose it on the first step.
Okay, thank you very, very much.
Thank you very much.